Wow. I remember back in March 2020, it was March break uh, the and I was deciding, do I go down to Aruba and join my family for March break or not? And I remember is that the family left on Saturday morning, and I decided to stay behind. The next day, my wife called me and says, "Come on down to Aruba." And so I went to Aruba the following day. I remember on this big Air Canada plane, there was probably 20 people in the plane, and I was one of them. And I didn't know what the word COVID really was at that point in time. I don't think anybody did. Boy, we learned a lot since then. And I remember basic immunology when I was a medical student. And COVID is a brand new disease. We learned a lot. And if I remember correctly, there's been about 12 billion doses of vaccine given so far. Um, and so we're going to learn out where we are with that COVID, masking, long COVID medications, vaccines, and beyond. And it's a very controversial area. I don't know why. In fact, it's the most well-studied disease so far because it's happening in real time. The disease has changed. I remember working on the COVID ward and seeing lots of people, unfortunately, being very sick, many passing away. I remember walking through the ICUs at the Hamilton General Hospital and just seeing rows and rows of ventilators with people on respirators. And they built a MASH unit just outside the hospital. They built a hospital that they never used because the hospital system was almost going to be overwhelmed. Now we still have a lot of COVID. I'm glad it's not killing us to the same degree. But what have we learned? And so the teams put together this wonderful presentation. So we'll try to take the politics out of it, put the science, and let's learn some more. Tell us.
Alrighty, first you said let's keep the politics at her. We're going to start with the most controversial part, masks. Why do we still mask at the clinic? Anybody who's been a patient of ours. So we're going to talk a little bit of the evidence and a little bit of the risk aversions and how risk tolerances differ. So first of all, before going into detail, I just want to quickly mention this quote that I really like. It says, life is all about probabilities, medicine is the same. I think the next slide here we have a quote by William Osler: medicine is a science of uncertainty and an art of probability. So the reason we put this in is because when you look at the things you do from a daily basis, what kind of tire you choose in the winter time to what kind of boots you choose to wear when you're going on snow, you're making decisions to reduce your risk. And so what we're trying to do in our clinic is, because we see a lot of patients and ourselves as well, but mainly the patients who have different comorbidities at risk of COVID. Now, most people are vaccinated, but I've seen a few people who have not been, or even despite vaccination, they're still at risk. So what we're trying to do really is stack the odds in our favor with anything we can do. So that includes masking, includes boosters, other things like Paxlovid, which is new for us in Canada, more used in the States, although albeit not as much as some people like, as some physicians prefer. So this is our strategy and philosophy going into this. Now, about masking itself, interestingly enough, you would think that of all COVID topics since 2020, we would have learned a lot about masking, but in fact this area has been one of the least researched areas in terms of good quality trials. We have a few trials. This was actually a very recent one done in Norway, published this summer. It was done last year, but published this summer. There was one in Bangladesh. We've had one in Africa, and they found different effects. Most of them positive, but very, very small. But this last one was quite interesting because one, the magnitude of the benefit was interesting. So what they did was they took around 4,600 people in Norway, and they sent them masks. And they sent them masks. Half of them wore masks in public for 14 days, and the other one were just asked to go about their day as usual. And then what they found after 14 days, the self-reported symptoms for any viral illness was reduced by 29 to 30%. So it was like 29 something, let's say 30%. That's very interesting. We haven't had a trial like this yet. The Bangladesh study, which was very highly cited, very similar to this, they did the same thing. They found 9.8%. So again, the percentage is probably not the most important thing, but the important thing is that there's a non-zero benefit with masks when it comes to reducing infections. And that's why we try to stack the odds in our favor. So this is a recent
So,
trial.
so this is that I remember at the start of COVID, there was the randomized control trial done in Sweden where they asked people to mask or not mask, and it showed a 25% reduction in getting COVID infections back then. Um, this is actually showing a 30% reduction. So this looks really real to me. This is a randomized control trial. The trials all points in the same direction. It makes sense if you have a respiratory illness or disease that's transferred through the air, filtering the air leads to benefit. And so and there's lots of respiratory infections. There's a common cold, there's influenza, there's pneumococcal pneumonia. And this is a trial that's big, 4,600 patients. And they were asked or given masks to wear for a period of a couple of weeks. And it shows a 30% reduction in respiratory illness. So my takeaway of this is it's not a big ask, is that masks are like seat belts. They don't stop you from crashing the car, but they soften the blow. And at this stage of the game is that if I see a crowded bunch of people, I go the other way. If people are coughing, I avoid people. And in crowded places, wear a mask. It protects you. And the number one reason to actually wear a mask historically is to prevent if I have COVID and I put this mask on my face, I decrease the chance of making you sick. Now, and the evidence to support that it makes you less sick is also here too as well. So it's a no-brainer from my perspective. Is that wearing a mask protects other people and it protects you. And here's a randomized control trial, 30% benefit in any respiratory illness. Best way to treat infection is to prevent from happening in the first place. Tell us more.
Absolutely. You know, something I've wondered myself is why I think we've done this. I'm just haven't looked deeply enough in masking in places like cinemas, planes, actual trials. And I saw this systematic review shared by Eric Topol. He shares a lot of studies. I can't keep up with them, but he's wonderful with the studies he gives the world. But study was interesting. If you look at the right diagram, you can see that the longer the flight was, the higher the risk of COVID was. And wearing a mask reduced the reduction to the point where if you follow my cursor, this long one right here, that's without masks, this long bar graph right here, and then the one to the right is with masks. So you can see, and this was, I believe it was all masks, they didn't specify, but either or surgical or N95, it reduced the infection rate. So again, just another piece of evidence.
Well, actually, go back a little bit over here. So Eric Topa says the risk is 25 times difference. Is that right?
Again, I wouldn't read too much in the
Yeah,
absolute value. It's more the
that's fine.
relative that I look
Yeah.
at. Yeah,
So,
yeah,
so we're going to talk about different forms of mask as well.
yeah.
Um, putting a hand cloth in my face or putting a mask under my nose doesn't do any good.
Yeah.
Um, so we have a consistent benefit. Um, and tell us about the different masks that you discovered
Yeah,
here.
so when you talk about different, so actually there's been trials in healthcare settings comparing surgical mask and N95 respirators, and some have found a difference, but most have not. So but we're not going to get into that. But for the average person in a clinic, in a crowded area, you can see the filtration rate. This was just from one study. Again, the absolute values, take it with a grain of salt. But you can see the relative. The best is N95. Then we have surgical mask with ties, and then surgical mask with earlobes. So the only difference between those two, going from 38% filtration rate to 71%, is the more tighter seal that you get. That's shown in here. So the first one is what we usually wear under the top, 38.5%. Not bad, but it's less than other type of mask. And then if you actually tie the loops, you get extra filtration. I think, Dr. Curnew, you have something like a guard in the back of your head as well. Like that's something you use that actually increases it by a little bit as well. And then there's other types here as well. So if you use a clip, if you use rubber band, that might be a bit uncomfortable at this stage. But again, you can see the filtration goes up the more you close it off and reduce any leaks, so to speak. This last one, I haven't seen that yet, to be honest, but this person tried it, the nylon hosiery sleeve, 80% filtration, they tested it out. But interesting thing is that the lowest ones were with the cotton masks. So that's quite interesting to see. So if you want to get the best filtration, N95, and then the next best is a surgical mask, but with the tighter seal as you can get.
Okay, so if you go back to these other masks here, so to N95 means that 95% of stuff are filtered, right? A certain and one of the things is that one time people know me, I used to have a beard. If you put an N95 mask or any mask on top of a beard, you don't get a very good seal. And so I shaved my beard. The reason I had a beard in the first place because I was lazy, too lazy to shave is one of the biggest reasons. And in I have different masks, and I'm lucky. I get fitted every year to make sure that I have a proper fitted mask. So if you buy a K95 N95, depending on what type of seal you get, so I have some that that work because I worked in the COVID ward, and I remember people coughing in my face as they were saying goodbye to their loved ones, and they were using my cell phone. So I pray to God these masks work, and they do work. And so so if you really want to get the next extreme is that you have to get a properly fitted mask. So if you go to the next slide, and these nylon things, next slide over here, these things that you put, next slide, please. You put this polyester thing across your face. It's pretty useless. It doesn't really do that much. So the surgical masks, either 2 or 3 ply, are better quality. So anything is better than nothing, but you can see that, you can decide what type of mask you have. Thank you. Tell us more.
Absolutely, yeah. Again, masks are different, a little bit different in different risk factors, different risk tolerances, similar to what we said about choosing what tire you use, choosing what boots you use. This is also another question that we wanted to ask. How long is too long when you're staying with people? So this study compared for healthcare workers, compared the 2 different mask respirators, N95 respirators and most commonly used surgical mask. And you can see, to no one's surprise, perhaps the surgical mask did not perform as well as the respirator. But the good takeaway is the more you spend time, the higher the likelihood of getting exposed. So that's the idea here. The other idea here is, again, this was an estimation modeling study done by the CDC in 2021. It wasn't an actual study, but again, don't take the absolute values that I'm going to talk about too seriously. Look at the relative numbers, but you can see that the 2 rectangles, so we have 2 people who are speaking with each other, and neither of them have masks, you have 15 minutes to essentially get an infection dose. So the way I think about this is getting radiation. It's not the same thing, it's an analogy. We get 15 minutes, and then the more protection you add, what you see is that your time that you can allow with the other person goes up. Again, with N95s, 2 people wearing N95s, windows open, having HEPA filter, large area, 25 hours. In our clinic, for example, we have 2 surgical masks. You have 1 hour. So if you have an interaction with somebody in a clinic, 1 hour, at 1 hour you have to leave. Again, this is an estimate, but it's an interesting idea to send a message that the more you add different masks, you get this protection. Again, this is the model, it's an estimate. Just wanted to share this as well. Dr. Curnew, you mentioned source control briefly, that masks protect you from giving virus to somebody else. I want to show this clip right here that actually shows that visually. People get a better understanding.
What is the primary purpose of a mask? I think most people would say the primary purpose is to protect the person wearing it from infectious diseases. And that's not true. That is not the primary purpose of a mask. The primary purpose of a mask is source control. Yes, it's true that when you're wearing a mask, you are offered some protection to yourself from respiratory viruses. However, that's not the main point. The main point is to prevent you from spewing fewer viral particles out of your face. And yes, you can shed viral particles while you're infected every time you cough, sneeze, or do normal things like talk or breathe. All of these things can shed viral particles, and depending on what stage of infection you're in, you might be shedding a lot of viral particles, or you might not be shedding as much. You could also be pre-symptomatic, meaning you have not developed symptoms yet, or you could be completely asymptomatic, meaning you won't develop symptoms at all, and still shed virus. This means that it can be important to wear a mask even when you're not feeling sick, and that's why masks were heavily mandated early on in the pandemic, when we didn't know where the virus was or how widespread it actually was in the community. We did not know who had it or who could be shedding it, and we didn't have vaccines or antivirals to reduce our risk once we.
So I hope
I like that. I think it's a good visualization. So number one reason to wear a mask is if you are sick, you are transmitting less particles to somebody else, either bacteria or virus. And we also demonstrated that you have a reduction of 30% chance of getting sick. So when people say to me, is I don't understand how I got sick, I was wearing a mask. So the mask has a small effect, 30%. I think it's pretty reasonable. I'm seeing so many people right now, they went on a trip, they went on a bus trip with everybody uh, to Scotland. Everybody on the bus got sick. They're spending hours and hours together, days together, um, plane rides and things of that nature. So uh, I think it's worthwhile to think about masking in certain circumstances if that's what's something important to you to think about. Keep telling us more.
absolutely. Again, I hope that visual was a little bit more helpful for people to imagine what we meant by source control. You can see less aerosols and droplets coming out of the person's mouth. Now, this slide showing this was a challenge study. A challenge study is a type of study where we challenge volunteers, healthy volunteers, to again, it's an unethical type of study, but it's still done very rarely, where we give people a certain virus and test them out. So this study looked and tried to ask the question: does getting less virus matter, and if more viral dose makes more people sick? So they took 49 healthy volunteers, mean age 29, and they give them influenza A virus. And they found, if you can look at the dose, as the dose was increased by a log every time, so 10 to the 4, 10 to the 5, you can see that more people are developing symptoms. So 50%, 80%, 89, 85. Again, this hasn't been done with COVID. And in fact, we asked this question in a virology podcast last night, and we're going to have the expert respond to that quick question that we ask: if it makes a difference, if viral load, because what masks do as well is reduce viral load. They reduce the mRNA from COVID and other things as well. So just take a look and see what he has to say.
Here asks, do we know if viral load matters for infection or disease severity for COVID or flu? We don't know. I mean, for COVID, I mean, there are challenge experiments with flu that have been done. I don't know if they varied the dose, though. And the same with COVID. You know, the one challenge experiment was done, and they only used one dose. Oh, by the way, so anyway, I suspect if you got more virus in you, it would accelerate disease. I don't think it would necessarily alter disease severity unless it overwhelmed innate immunity, and that could lead to more severe disease because you might get an overreaction of the adaptive response and a lot of inflammation and so forth. So it could be. But, you know, people who say the viral load does matter for these viruses, it's not correct because the experiments haven't been done.
There we go. So the experiment for COVID hasn't been done, so we don't know exactly, because there's a lot of other factors. The person's immune system, especially when you're talking about if you get less virus, does it affect severity? That's more of a complicated question. And my guess, and from what I've listened to from the virologists and immunologists, is that for severity, it probably doesn't make a difference unless you're at the extreme ends. If you give very, very much virus and very, very little, that might. But for most people, it doesn't make that much of a virus. And
Actually, backtracking more.
Go ahead.
I look at it a little bit differently. So I'm very lucky is that I get to talk to a lot of very smart people. First of all, I'm just having some wonderful, healthy whole grain toast with a little bit of peanut butter and cinnamon. I want to thank the deacons. They came into clinic today and brought us some snacks. And so I always love to eat during these webinars. So thank you for all those who are kind enough to bring in a coffee or some nice healthy food to the clinic. Thank you. So I think, you know, you showed in one slide is that the longer contact you have with a person, the more likely you're to get an infection. You also demonstrated that with influenza, the more viral load that you give, the more likely you are to get sick. I kind of think if you're fighting a war, you have your immune system and you have the virus or the bacteria attacking you. And so a young person has a good immune system. We're going to learn that before the age of 10 years of age, you don't have a very good immune system. After the age of 60, you have also a bad immune system. So unfortunately, there's many wars going on at this point in time, and the more offensive and defensive capabilities you have, the better off you are. And so I think this makes some sense. But a lot of things make sense and don't pan out to be in clinical trials. So at this stage of the game, um, this if I'm sick, I make you less sick by wearing a mask, and I decrease my chance of getting um, a less sick disease as well. And the better my immune system, the better off I am. The weaker my immune system, we'll talk about, the worse off I am. And the more virus or bacteria, the worse I am. So that's my simple way of looking at this point in time. But you're right; it's we still have a lot to learn, and we'll stay tuned. So and by the way, that immunologist, we could talk a little bit more about this fantastic resource. Are you gonna mention that again at
Yeah,
all?
yeah, I had it at the end. But again,
Yeah.
anybody who has any questions, they have office hours, so they have clinical updates about COVID and other viral infections. They've been haven't had this for a long time, since 2020. But the page is on YouTube. It's called Microbe TV. They post a lot of amazing information. Anybody who's more curious, please check them out.
Brad, thank you for getting me involved with that. It comes out Friday at midnight, and usually Saturday is the day I listen to
Yeah,
what they have to. And I learned so much from these two amazing doctors. Tell us more, and from yourself
absolutely,
as well. Thank you for teaching me. Keep, keep,
absolutely, my pleasure.
keep telling us more.
And just as a TLDR summary, again, masks are not the only thing. We have this Swiss cheese model. We have different layers of defense. Keeping your distance is so important when you're in a crowded area, especially if you're have immunocompromising conditions and immunosuppressed, etc., etc. Now, what happens if you do get COVID? We're going to talk a bit about rapid tests. I'm going to pass it off to Amber, and she's going to tell us all about availability, etc., etc.
All right, so there are multiple COVID tests, but today we'll be specifically talking about the rapid antigen test. So these type of tests can be found or ordered in our local Shoppers Drug Mart or local stores such as Walmart. It can also be available at select walk-in clinics and pharmacies. Make sure you always ask your provider if you require some of these tests. And for individuals who already own a rapid antigen test, they feel free to always use an old rapid antigen test if you need to. However, there are some requirements you need to check. So you need to check if this test is still effective. So as you can see in this picture, you need to check how visible the control line, the C line, is. So if it's not visible, please don't use it. It's not effective. As long as the control line is visible, you can use it. So if you get a positive rapid test result, make sure to always wear masks. 85% of the transmission usually occurs in the first 5 days. Therefore, individuals must wear masks until day 10 of the infection. After day 10, if you won't really see much of a transmission because the amount of infectious COVID virus has already decreased substantially, but you can also see that you still have a relatively large amount of non-infectious virus, the graph in green, the line in green, and this is why. A limitation of one of the COVID tests, very popular PCR test. So at least for the average person is that you may test positive, but not actually be contagious anymore.
Yeah, absolutely, Amber. So again, this graph shows that 85% transmission happens in the first 5 days, and then up to day 8, 9, 10, you're really not really infectious. After 10, we don't really see much, and then beyond that, so PCR tests, I don't know much about the details of the guidelines of who it is recommended for, but again, a limitation is that you can still test positive even on an antigen test past day 10, 11, but still not be contagious. So the good rule of thumb is get a test when you're sick, and isolate for at least 5 days, and stay away from people till day 10 if you want to be on the safe side.
Yeah, I guess really important. So again, 85% of transmission, as you point out, the first 5 days, 15% day 5 to 10. By day 9 or greater, very low chance of you transmitting virus. Now, there's always some variation to that, but I think it's a good rule. So 5 days, ideally, if you can isolate yourself, 5 days of wearing a mask afterwards. So in my family got COVID. Basically, I just slept on my office couch, didn't go home. Um, and I think I think we'll just use with test available. Now the problem is these tests are getting hard to come by. Some will be outdated, and you mentioned very nicely that if the control um, antigen is shows that little line there, the test is probably still valid. If it's not, then the test is not valid. So I think we have it right now, and I think in Canada the government has phased out a lot of these tests, and I don't think they're going to be paying for them anymore, if my understanding. Does anybody know about that answer right now? Because I don't
We
think the
actually
government's.
checked today. Yeah, we checked on the Ontario website. It says for suppliers and organizations, you can still request them. But again, how much is available? That's probably a good question, and how many people can actually access them. But for the average person, you can't request yourself. It's for organizations. But if you go into a walk-in clinic, your family doctors, they might still have some supply, and they might be able to request a little bit as well. But again, you're right, Dick. It's hard to come by compared to a few years ago. All right, now vaccines. So for COVID and the flu, I just want to show what's happening with how much is going on. This is the latest data we have from Canada. You can see Toronto. We're in a moderate state right now, but right now it's October. This data, I believe, is updated late September, so September 22nd. Again, this is wastewater data. It's not perfect data. It gives us a snapshot of what's going on. So what we're going to anticipate with flu and COVID is that we're going to see a rise in January and February, and the usual recommendation is get it when you usually get it. For the flu vaccine, some people say get it by Halloween. I think that's just a memorable way for people to remember it. The other question is COVID the same as the flu? I think a lot of people will probably have this conception that a booster is probably not necessary. I don't, it's just like a common cold. It's like the flu. It's not like that when you think about it. So this is data from one of the seasons where a lot of people actually were vaccinated, 2022, 2023, and we still saw that against COVID, comparing to it with the flu, a lot more hospitalizations. Again, this is U.S. data showing that hospitalization risk was 4 to 5 times higher for COVID than for the flu. So again, I hope this makes it clear that they're not the same. COVID still has a higher risk.
So that's actually very, very important. COVID is 4 to 5 times more likely to cause you to be hospitalized and unfortunately kill you. And I'm not saying you're going to die, but that's a pretty risky virus. It's a nasty virus. I remember talking to my immunology colleagues and saying, this is a cytotoxic virus. Cytotoxic means it kills cells. And right now, many people's infections are relatively mild or asymptomatic. Somewhere between 30 to 50% of people will be asymptomatic with COVID infections. But it does cause damage inside, and there's recurrent infections inside cause damage to your brain, to your heart, to your pancreas. The answer is probably yes. I don't want to be a fender bender, so tell us more.
Absolutely. Yeah, again, we're going to talk about some of the effects on the multiple organ systems, the brain as well. So what the recommendation for flu has not changed, but one thing we want to emphasize is please, anybody who has any immunocompromising conditions, there's something that I've coined for myself, health complacency. We see it a lot. We think that we're protected. It's not going to, bad things are not going to happen to us. But again, if you're in that age group, I'm not sure if anybody listening to this is 70 plus, 80 plus. I hope there are some. But if your family member is in that age group, please get the flu shot. And the other thing is, there's this misconception that it's supposed to prevent infection. That's not the purpose of majority of vaccines, the flu vaccine, the COVID vaccine, are no different. The purpose of it is to make wild flu into mild flu and prevent you from going to the hospital. Again, that's the purpose. That's why you get the flu vaccine. And the vaccine you get for the previous season does not work for this season. And it's not because of waning immunity for flu. It's because strains change, and the vaccine that we gave you last year, the protection you make, even we have the memory protection that you do create. There's things that are called memory B cells that we're going to touch on in a few slides. They're not as effective against the new strains. And that's why we have COVID, updated vaccines, and flu vaccines. So just remember this little diagram on the right as well. Don't let us chase you. Please, please, please. If you have any conditions that puts you at high risk, please get your flu shot.
Well, this goes true for all infectious processes. So you can see that little babies get protection from their moms initially, and between 6 months and 5 years, little children are very vulnerable.
Yep.
Pregnant women are very vulnerable because their immune system is suppressed, so they don't reject the baby. Now, one of the best predictors of how good your immune system is age. So those that are 60, and basically your immune system between the ages of 10 to about 40 or so is a pretty strong immune system, and then it starts to wax and wane. And at 65, you lost a lot of your ability to fight infection. If you have many cancers, you lost the ability to fight infections because you destroy these cells. Heart disease, cancer, diabetes, kidney failure, hypertension, anemia. These are all risk factors. Being overweight, these are all risk factors for a weaker immune system. So those are things to think about. And unfortunately, the highest mortality from COVID was in older people, in the nursing home population. That's where we saw the vast majority of our RPT rate.
And just to add on to that, I remember looking at the data from the United States from the beginning of the pandemic until last year. The top cause of death, so it was a direct cause, but the top comorbidity with COVID was actually having flu with COVID. So we did not see flu completely go away during the pandemic, but that was actually the highest number of deaths that was in this death certificate. So don't think that you're not going to get both at the same time. It can happen, and so want to get both vaccines if you can. Again, as a bonus, we wanted to talk about this. The flu shot can reduce heart attacks. There was a trial done in 2021, the IME trial, that randomized people to flu shots over a few seasons. I know, Dr. Curnew, you have some thoughts on this. We just put a systematic review here that shows that if you get the flu shot, aside from taking flu from wild to mild, you also get some heart benefits and lowering heart attack risks and such.
This was an amazing trial. It was very smart people that during 3 flu seasons, if you were admitted to the coronary care unit because you were having a heart attack or a problem with your heart, you were randomized to getting the flu vaccine or no flu vaccine, and followed over time. So 3 consecutive flu seasons. And look at this. It lowered the risk of a cardiovascular event by about 25%, cardiovascular event by close to 40%, all-cause mortality by 1 in 4. Amazing. We don't do as good with many of our cardiac interventions. We give you I'm taking aspirin. Aspirin decreases the risk of a heart attack, or by about 10 to 15%, increases the risk of bleeding complications by 40%. Historically, beta blockers decrease risk of repeat heart attack by 25%. Is that all these procedures are helpful, and I'm grateful for them, but a simple, stupid flu vaccine, influenza damages vessels and accelerates atherosclerosis. And look at the benefit. This is huge. So one of the reasons why I'm going to get vaccinated every year is to prevent a heart attack. And so I'm also taking it to prevent the severity of getting influenza. And the vaccines are between 30 to 60% effective depending on the season and did we get the right strains, etc. But this is very impressive data. Damaging vessels through infection is not a good idea.
Absolutely.
Keep telling us more.
Absolutely. And so you saw the flu recommendations, again, hasn't changed. This is the the recommendations for COVID vaccines. It's a little bit different than last year. Last year, anybody over the 6 months of age was recommended to get it. This year, there's just a slight nuance that we just want to focus more on some of the people who are at higher risk, but still anybody who is able and willing, not a bad idea to get your vaccine this fall. Again, when you think about the risk, the safety issues, nothing new has been seen. There was a question of, can you get the COVID vaccine with the flu vaccine at the same time in the same arm? The answer is yes. In fact, that's in the National Immunization Guidelines that you can do that. In fact, it's probably recommended so that people take both when they go to the pharmacy, when they go to the clinic.
I've actually seen different trials report on whether or not it should be the same arm or different arm, showing mixed results about that.
In terms of reactogenicity or efficacy, Dr. Curnew?
Efficacy.
Efficacy. I actually did see something as well. There was one trial that showed slightly better when it was in the same arm. But I asked an immunologist at McMaster as well. I emailed her about this and said, look, it's a nuance. Don't worry about it too much. Just make sure people get it. It's like, okay. All right. Now, I just wanted to tell you guys about this. So the reason we have boosters is because of this. So we have different layers of protection. We have antibodies on the left. They're different proteins you can see here. Very, very small proteins. They work differently, but one of the ways they neutralize a virus is by overwhelming it and preventing it from infecting your cells. The other layer of protection is something called memory B cells. Anybody who's been with us for the past 10 minutes might have heard me say memory B cells. These are the hard drives of your immune system. They save the antibody information, which is quite specific. It's specific to the flu, specific to different strains, and that's why it changes. You can have many different memories against all kinds of different viruses. That's where it's saved. Memory B cells. And they actually can make these purple antibodies, you can see. And that's why your immune system remembers. And then you have T cells on the right. You have the killer ninja cells. These ones kill infected cells. Now, the reason you need boosters, or some people need boosters, okay, not everybody, is that as you age, your T cells right here, both the number and the function changes. So as you grow older, there's something called the thymus organ. We have an organ right here. That's where the T cells go mature and gain functionality. And as you grow older, there's more fatty replacement in this tissue, and the T cell function becomes less and less, and that's why you need vaccines. And that's why for some people, the T cells may not be enough, and the antibody is a greater tool, right? It's one of the layers of mechanism we try to maximize with these boosters that against severe disease lasts between 3 to 6 months. Somebody who is younger, not a lot of comorbidities like myself, it's a different story, right? So I have all 3 layers of protection. However, I want to say this. One of my best friends, he ran the marathon with me. He has ulcerative colitis, and he takes medication for he's gotten COVID 3 times, and he's been vaccinated 3 times. All 3 times, he got very severely sick. So you don't want to think that just because somebody is young, you're protected. There's something called long COVID, which we're going to talk about. It does damage, but also it's not all about T cells for some people. Some people just need more protection. Again, you have immunocompromising conditions. The vaccines are a great tool.
You know what I find really amazing about the immune system is that there's different layers. If you go back one slide again, is that you have you have all these cells, these T cells, these B cells, these antibodies from B cells. You have these neutrophils, white cells. These are these cells that go around the body looking for foreign substances and attack them. So what your immune system has to do is figure out what is your own cell and what is a foreign cell. And then we have some of these viruses or cancer cells that actually hide in normal cells, and they take over machinery. They actually try to fool the immune system. And so it's really quite a complex world out there. And the first layer of protection is basically a very non-specific response, is that you don't need much preparation. These are the cells that suspect that there are some foreign cells in there, such as bacteria or cancer cells, and they go and destroy them. And then there's these other forces, such as B cells, that secrete these proteins called antibodies that are very specific to its target. And that takes a while to rev up, and that's what the vaccine does quite well at that. It revs up um, uh, um, these protein molecules, these antibodies that go attack them. And so there are some memory cells, and then after vaccines, your immune system is boosted for a period of time. And what turns out for COVID is that very quickly, within a few months, you start to produce protection within about 2 weeks after being vaccinated. We'll talk about a little bit more. And maximum protection is really in the first few months, first 3 months probably. And then after 6 months, you lost a lot of the immediate protection. So for instance, if you're going to plan to go on a trip, I would ideally, before going on a trip, is get my vaccine 2 weeks before a trip, so I have my immune system ready to fight. But keep telling us, keep telling more. It would be great if the
Absolutely.
vaccines. So it's not a great vaccine at preventing illness. It's a better vaccine at protecting against severity of disease and long COVID, which you're going to talk about. But in the first few weeks to few months, it does give better protection about getting sick. Um,
Yep.
and as you get older, you get less protection. So someone like myself who's 65 years or greater, I would like to get a vaccine every 6 months for COVID at this stage.
Absolutely. You mentioned it's not really for infections, for severity and hospitalization. This is what the data is showing right here. This is from last year. Obviously, this year has not occurred yet. We haven't gone through the winter, so we don't have the data. I wish we did, going to the future. But this is from last season, the 2023-24 season. And it's the efficacy of the boosters that people got last year, the XBB lineage. And you see the different data. So there's a claim at the top about the vaccine didn't work last year. The reason is partially stated here. It was not utilized very well. So we have 18 plus, only 11% got the vaccine, and for older folks, we have 57% hospitalization. And what you see here that against JN1, which is the one we have right now, the updated vaccine is KP2, which is a JN lineage. Compared to baseline vaccination, that's 3 doses. That's the reference value right here. You still get extra protection against severe disease up to a certain point. So up to 180 days, 6 months. You can see that if you look at my cursor right here, vaccine effectiveness ranges from 20 to 60%. So again, this is data from last year, and who knows what's going to happen this year. But this is more of a myth buster to the claim that they do work. It is just that they wane. So again, for people who need it, it's very important.
If I remember
go ahead.
correctly, that current data suggests that 85% of people who are hospitalized at this point in time have not had their updated vaccine in the last year or two, if I remember correctly. And so as I tell us about tires. Tell us about maintenance.
We love tires, yeah. So we mentioned we want to stack the odds in your favor if you are at risk. Again, we want to talk about people who are at most at risk. If you have family members who are at risk, when you are, let's say somebody's at risk in terms of crashing on the highway. If you drive along the highway, you have to decide between choosing an all-season tire, a flat, a worn-out tire like shown here, or a proper winter tire. But there's no guarantee that you're not gonna crash, you're not gonna slide on a highway. And it's the same exact thing with a vaccine. You try to reduce your risk and just stack the odds in your favor. There's no guarantees, right? So we talked about it's going to take it from mild to mild. Again, we hit the point. I hope we hit the point home with all these analogies and all the data.
So on the left, that winter tire, that's a 20-year-old. That's a 20-year-old immune system. That ball tire on the right is an 85-year-old immune system. It just doesn't work to the same degree. Again, seatbelts don't prevent the accident; they prevent the severity of the accident. So I think this is all, and I do think there is some protection about getting COVID, especially in the first few weeks to few months, and we'll say after about 3 months or so to 6 months, doesn't really prevent you from getting COVID, but you have these memory cells that can be activated quicker. So And so the virus changes and your immune system cannot be on guard again forever. It would be great if that could happen. Certain diseases. Look, we don't have a vaccine for HIV, and that disease has been around for a long time, but we have very effective therapy for pneumococcal disease, and we have for shingles. Um, so lots to learn about. Let's keep telling us more about other vaccines as well.
So these are the additional vaccine information chart for fall 2024. The first one is seasonal influenza, also known as the flu. So this vaccine targets 3 strains of seasonal flu, and individuals who are older than 6 months can receive it. It's found to reduce the risk of going to the doctors by 40 to 60%. And individuals should receive it ideally October for 2024, as vaccine protection diminishes over time. Remember, it's flu season recent now. Make sure you get it as soon as possible. For COVID-19, this vaccine now is an updated formula targeting JN.1 Novavax, as Rad mentioned earlier, and KP2 by Pfizer or Moderna. These are set to be authorized in fall 2024 and is expected to be available this October. Anyone who is older than 6 months can receive this vaccine. And it's found to provide 60% additional protection against severe diseases last fall. For those who need to get this vaccine, if you were recently infected by COVID-19, wait 4 to 6 months. If not recently infected, either receive it now or wait to increase protection against the winter wave. Third one is RSV. There are 3 RSV vaccines available: GSK, Pfizer, and Moderna. This isn't an annual vaccine, so if you got one last year, you don't need one this year. People ages 60 and older may get the vaccine, and those who are 75 years and older should get the vaccine. And you should get it ASAP. Get it as soon as possible.
Just backtrack a little bit over here. So the RSV was initially a disease of young kids, and right now the vaccines aren't good for kids. That there's immune globulins that you can give. Now we have a vaccine that's available, and it looks like it lasts for at least 2 years, maybe longer. Currently in Ontario, it's funded for people in nursing homes. If not, you have the government of Ontario is not paying for it at this point in time. It's relatively new sets of vaccines, and it costs just under $300. But COVID and influenza vaccines are covered in Ontario and basically across Canada for anyone 6 years or greater at no cost to yourself.
Moving on, we have Prevnar 15 and 20. So this is a vaccine for pneumococcal infection, which can exacerbate lung function and cause pneumonia. Individuals or infants around 2 months should receive 4 doses over time, and individuals over 65 who has never received Prevnar should receive it. And you can receive the vaccine whenever possible. Next up is shingles. So the vaccine for shingles, this shingle causes skin rash with blisters. It can also elevate the risk of cardiovascular events such as stroke and heart attack. Individuals older than 50 can receive this vaccine, and you should receive this vaccine whenever possible. Tdap, short for tetanus, diphtheria, and pertussis, anyone who are adolescents to adults can receive this. And once received this vaccine, you should get a booster shot every 10 years.
So go ahead, keep telling us more. Go ahead.
Yeah, so just want to tell you guys about the Prevnar. There's an update this year that the 15 is replacing the 13 version. That's the only slight accommodation there, but the eligibility has not changed. So again, this chart, you can pause and take a look.
So there's different forms of vaccine. So the vaccine you should get right now is called Prevnar 20.
Yeah.
I had Prevnar 13 before. I paid for that vaccine, but right now it's covered in Ontario for those over the age of 65 to I think 75, if I remember correctly. I can't remember the exact cutoff age. And basically it's a covered vaccine. Pneumococcal disease is so-called the killer of older people. It's a bacteria infection. In fact, this is a very interesting story. Pneumococcal pneumonia is a disease that used to be it colonizes your nose and it goes into to your ears and gives you ear infections, and it goes into your tonsils, giving you tonsils. And remember when we were young, is that tonsil infection and tubes in your ears were relatively common. Now, young individuals in Ontario and across Canada are vaccinated in when their childhood, and basically otitis media and tonsillitis is basically the disease has gone away. And also used to be that little baby Johnny would have pneumococcal in their nose and spread it to grandpa, grandma, and kill them with pneumonia. So Prevnar vaccines looks like it's a durable vaccine. In kids, it may be durable for your entire life, and that's something that we're learning about. So I had my Prevnar 13 a couple of years ago, so I'm now eligible to get the Prevnar 20, and that just adds more serotype to that. And so this is actually an improvement right now. So since July 29th, 2024, it's a funded vaccines for seniors in Ontario, and also some individuals that have certain immune diseases. If you backtrack a couple slides, shingles, if I remember, do you remember what percentage? So shingles is basically chicken pox that gets reactivated. Chicken pox infects you, and then it goes back into some nerve cells, and it gets reactivated, especially if you get older. And I forget what percentage of people will get shingles in the future, but I remember numbers of 25 or 50%, somewhere in that ballpark figure. And a certain percentage, and I saw a patient today, can get prolonged pain afterwards. So right now it's a funded vaccine. Shingrix is 2 vaccines. So that's a good thing to have. Unfortunately, I think tetanus has affected 1 person in Canada in the last 50 years. And unfortunately, tetanus, if you get tetanus, it carries, I think, 100% mortality. And so getting the appropriate therapy for tetanus is important, and getting vaccines are an important consideration. So now we have to store vaccines. Tell us about the Can Immune app.
Yep. So we forgot to put your record in here, but anybody who wants to, again, so something I heard from a conference was that most people carry their phones, even if you forget your health card, forget your wallet, etc. And if you want to save your vaccine records online, there's an app to do it, Can Immunize app. You can put your COVID vaccines in there, and it also gives you reminders of what the ones you qualify for, reminders of when you have to get your boosters for certain vaccines, etc., etc.
And you can actually put other family members in there as well. So, and it also has information. And so it's actually a source of information about vaccines and a storage place for vaccines as well. So I think it's kind of an important thing. And I think that should be the standard. Again, growing up, we got those little yellow cards. I don't know what happened to my yellow card. And basically, how do you fill this out? You ask a young person. So Rad, next time in your clinic, or Amber or Sharon, if you can help me figure this out. Yeah, thank you.
Now, what are the other COVID treatments? Amber, tell us about Paxlovid a little bit.
Of course. So Paxlovid is an oral prescription. It's an antiviral medication developed by Pfizer. It contains 150 milligrams of nirmatrelvir and 100 milligrams of ritonavir. This medication treats adults who have mild to moderate COVID-19, and those who have had symptoms for 5 days or fewer and or have a high risk factor for progression to severe COVID-19, such as being 65 years or older or having certain healthcare conditions and or lifestyle factors.
Okay, so how effective is it? Now, I think for most people, if you haven't got any vaccines, the effectiveness against severe disease is 78%. This was not the randomized trial. This was it was observational data. The study that actually got this drug approved, that done in 2022, it was for people who were unvaccinated, and they got 89% reduction of disease severity, which was interesting. Now, I think we mentioned that you have to take in the first 5 days. You cannot take it after that. There's a chart. We'll talk about why. The first 5 days, we have the viral phase where the virus is replicating, and after that is the inflammatory phase where things like antivirals and Paxlovid are not as effective. However, people who have gotten multiple doses, here we don't have data for 4, 5, 6 doses, we have for 3 doses. The reduction in disease severity was 29%. Now there's a question, a very, very important question of, is it cost effective? The drug, we have the cost right here. It costs $1,300. We're going to talk about the limit to use criteria. It is funded in to some extent if you meet the criteria that we're going to talk about. But it is expensive. It is a question that people have to think about. Go ahead.
Like Killing again, the cost in Ontario is about $1,300. And go ahead, tell us more. And this is its limit use criteria in Ontario.
Absolutely. So the limited criteria, there's 3 groups. One is those over the age of 65 with a positive test. That's the first group who qualify. And in the first group, you don't have to have immunocompromising conditions. The second group is 18 plus all the way to 65 who are immunocompromised. And the third group is 18 to 65 with at least one risk factor. And we looked at the risk factor list. In fact, if you want, I can show you we have the website open. But it seems like there's a bit of subjectivity to it. Again, correct me if I'm wrong in terms of the third group. Maybe I can quickly show from the formulary. So this is anybody who wants to take a look. You can look at the Ontario Drug Formulary, look at the limited use criteria. You can see the criteria here. This is for the first group. You have to have positive test, use it for the first 5 days. The second group, immunocompromising conditions. There's a list here of things that is included as immunocompromising. So people with cancer and those type of things. And the third group, people with various risk factors, medical conditions that are listed here. Anything else, Dr. Curnew, you'd like to add about this? Let us know.
No, I think it's very interesting is that the earlier you treat, the better off you are. And it's sort of like you mentioned, you start off with playing the probabilities. And I think a question we have to ask ourselves is that at $1,300 a dose, where should governments and yourself spend their money? If there's unlimited resources, then there wouldn't be a question. Right now, we are in a healthcare crisis. We have been, we will be. And depending who you talk to, I was listening to your webinar last night from our experts, and they feel anybody who's 65, anybody with risk factors should take it. And who cares about being cost effective? A life's a life, and that's a very reasonable thing. But unfortunately, is that we can't fund a lot of things. We have to make choices. And I was talking to one of my immunology colleagues who's a PhD, and what he would do is that if you have COVID and you're asymptomatic, he's not looking to put you on this drug. On the other hand, if you're starting to develop severe respiratory symptoms or respiratory symptoms before they get severe, and you are over 65 or you're 18 to 64 and lots of comorbidities, and that would be a very reasonable drug to be on. If I'm having diarrhea as my major symptom, I'm just not sure that's the best way to approach that. So what we learned from the first phase, and thank you for pointing this out, the first week of COVID is basically the viral phase, and the second week is the inflammatory phase. It's when the body overreacts to this attack, and and all your inflammation takes place, and it's not really related to the virus replicating. It's your body fighting the disease that's gone haywire. So these are important considerations. So if you're going to use Paxlovid, you have to do it when the virus is replicating, and that's early on. And I think you'll have these debates from some people who feel you shouldn't use it too often. To people, you should use it anybody who's at high risk, so anybody who's just 65 or who have
Yep.
risk factors. And I think you'll have that debate that will continue, and you have to decide for yourself if you want to be on these two antivirals, because Paxlovid is two antiviral agents
Yep.
together.
Yep.
I just wish it wasn't so expensive.
Oh, I'm not sure if it's going to change in the future, but we'll see. I don't know much about the pricing of things. It's a complicated world. But one thing I wanted to mention about this, again, we said there's a viral phase in the first 2 weeks. So the first 2 weeks is the incubation period when you're asymptomatic, the virus is replicating. However, the important thing is you can only take Paxlovid in the viral phase and not in the second phase, the first 5 days. You can't wait to get very sick and then get it. It won't be effective. You have to get it when you test positive within the first 5 days. That is when it's recommended. Beyond that, not so much. So that's a quite important distinction. If you're going to spend the cost, you can't wait too long.
So let's go. If you look at your slide here in the first 5 days, let's say you're asymptomatic.
Yeah.
When you don't know when day zero is, but let's say you just knew, then there's no rush to be on it. But if you start to get significant respiratory symptoms, I would say by day 2 or so, if you're getting really sick very fast, get on it very quickly.
Yeah.
And again, it's a very, I can understand the debate, but to be safe, take it. On the other hand, if being cost effective is also important too as well.
Yeah.
And it would be nice if we can actually redo this trials because COVID, the disease has changed since its initial clinical trials. And it's not as a severe disease as it was before.
Absolutely. Just want to talk about long COVID now and some of the impacts it has. We wanted to mention the ACE2 receptor. This is the receptor. It's like the locking keychain that the virus enters different parts of the body. The lungs, the kidneys. It's in all sorts of places. You can see the blood vessels there. SARS-CoV-2, the virus, and the infection is also associated with the acceleration of atherosclerosis to a certain extent because of this inflammatory phase that it causes. So we're going to talk a little bit more about long COVID, what even it is, what the definition is. If you look at this slide, this was a consensus statement that was published recently because different places define long COVID differently or slightly differently. But the definition is that any diagnosable symptom or condition that happens intermittently or continuously after 3 months post-COVID infection. So the important thing is that with other illnesses as well, you can definitely feel not 100% recovered a few weeks after your infection subsided. So this is a little bit different. This is after 3 months that people are still having some of these symptoms on the slide, and you can pause and take a look. Unfortunately, there are no clear biomarkers to test for it. It's a very difficult thing to diagnose. It's a diagnosis of consistency of symptoms. If somebody has these symptoms for a period of time, there's no other obvious reason, and so that's when the diagnosis is a little bit closer to long COVID. In terms of therapies and treatments, nothing approved yet. We're going to talk about some potential ones in a bit. In terms of some of the causes, it's interesting to say that long COVID is not one chronic condition. It's an umbrella term for different things that can occur. So multiple things can go wrong. We have some of them right here: viral persistence, immune dysregulation. Interesting that your microbiome has something to do with long COVID. COVID can use a dysbiosis in your gut. Who would have known? I would have not guessed that. You have endothelial inflammation. It affects the neurons in your brain. Again, the mechanism of how, I don't know exactly, but we have some evidence on the following slides on impacting your brain that it does. Again, the cause is multifactorial, and the effects are multifactorial. So essentially, it has different phenotypes, different presentations. You can see some of the symptoms here. being more out of breath. We have something called POTS, where you have this dysautonomia, and we have affecting your gastrointestinal tract. We have the pancreas. We have general fatigue, which is actually one of the top symptoms of long COVID. We have brain fog, palpitations, chest pain. So you can see there are different phenotypes. It's not one disease. It's multiple conditions under the same umbrella. Just want to make sure we cover this. Who is at risk?
Go back a little bit.
Yeah, go ahead.
Basically, you can see where you mentioned that COVID gets through the AT2 receptors. So the if you go to the next slide, please, the AT2 receptor is part of the heart. Next slide, please. Go forward one more slide. And you can see that if you
Is it this one? This one?
yeah, no. Go back one. Go back one. Okay, go next slide forward. I'm sorry.
Maybe it was this one. Yeah.
There we go. So again, if it involves the heart and the blood vessels, you can see that it can damage the heart. POTS is basically the heart's going inappropriately fast heartbeat and gives some chest pain. It obviously involves the lungs. You have gas exchange, shortness of breath, and cough. We also learned that COVID damages the pancreas and accelerates diabetes. If it affects the brain, it actually causes strokes. It causes clots in the brain. It causes memory loss, fatigue. And you're going to learn that even people who are asymptomatic with COVID, if you test your brain function, it's reduced. And depending if it's in your stomach, you get GI symptoms. So you can see that it's a very systematic disease and it affects your immune system, and probably it's going to accelerate different forms of cancer as well. So it's a disease that goes through multiple systems, and depending where it attacks predominantly, this is some of the consequences that you get. Remember, the first phase is the infection phase. The second phase is how your body reacts. So tell us about these risk factors.
This is quite important because I think, if I'm a patient or anybody at risk, I want to know, would a young person be at risk? So take a look here. The number one risk factor is actually not being vaccinated. That's number one. After that, pre-existing conditions, that's a huge umbrella term. But being female is associated. There's some socioeconomic status factors, which, that's more of a public health standpoint. Having more severe symptoms in the first few days, that's one. Being hospitalized is one. Being unable to, this one, I was surprised to see this, that they found this in the data, being unable to rest during the initial illness. So giving yourself less time to recover. No antivirals used during initial illness. So there's a bit of a controversy around Paxlovid to begin with, but also Paxlovid for long COVID, because in terms of Paxlovid as treatment, it has not worked well. They have tried, but in terms of preventing it, there's some evidence. So I guess that's one more. If you want to say into the cost effective, that's one more point.
Well, I think go back to Paxlovid again. If you have the viral blood, just go to your slide there. Don't change that.
I'm trying to go to Paxlovid. Which one?
No. Just go back to your normal slide.
Sure.
Long COVID there. So just stay here for a second. So basically, initially the virus is replicating, and it's going to make you sick. And if the virus stops replicating, then Paxlovid is not going to work. So some people feel that it's a residual virus left in your system. So they did a trial with prolonged Paxlovid, and it came out negative. That does not mean that some people might have some isolated particles left or somewhere in your body, but right now we haven't been able to prove that as a major factor about this. So this is very consistent with the data here. And the more virus you get, the bigger the injury, the more likely you're going to have long COVID. That's simple.
Absolutely. I think the viral dose is a good point there. Yeah.
Is that being vaccinated decreases long COVID by probably around 30 to 40% or so, is my takeaway about this.
And you asked about reinfections. If you get it multiple times, the study looked at this. It was observational, of course. And so again, 1 infection, 2 infections, 3 infections, the risk goes up with every infection. The risk of developing long COVID. So if you got it once, you were fine. It's not a guarantee that the second or third one would be a walk in the park, so to speak. Even if it was, you were sick for a week, the same thing had happened. In fact, my close friend was, he beat me in the 5K last week. He broke a record. He got on the podium among many people. Every 3 times he got it was sick for a week. In his case, a little bit different, but outside looking in, healthy guy, and he gets sick that much. So, how long is long COVID? That's a good question to ask. There's a study that looked at people with long COVID 1 year after infection. 85% of them still had some symptoms from long COVID. Again, the trend is towards recovery, but it still persists for some time. And then after 2 years, you got 61% still have it. So that's why it's a chronic condition. Some people recover from some symptoms of it, but it's a little bit difficult. It's an insidious disease.
I think most people do recover from it. It can take time.
It seems to be, yeah, but it just takes time, and maybe some phenotypes longer than others. Yeah.
Well, and I think as we were looking at that immunology lecture we both listened to, was that it tends to affect people in their 30s and 50s the most, and that's when your most productive time. So let's say you're 40 years of age and you're paying off your mortgage, you have your kids going to school, and now you're sick for 2 years, fatigue, brain fog. Holy cow! You can probably just decrease the chance of this happening by being vaccinated. So yet don't get infected in the first place.
Absolutely. Now, COVID in the brain. Hopefully you appreciate the diagram here a little bit. Viruses in the brain. So what happens here? We have 3 different studies here for you. One is long COVID is associated with severe cognitive slowing. This was a very interesting paper in the UK and Germany. They took 270 people who had long COVID, and they compared them to 2 other groups. One, people who had got COVID, but they said they're not experiencing any long COVID symptoms, and another group who didn't have long COVID and had not gotten COVID. And you can see at the bottom left diagram that on this objective test, I think it was a reaction time test, so it's not everything, but it's part of cognition, that they were objectively slower. 30%, around 30% of those who said they were fine, they had objectively slower results on this test. So that's pretty remarkable. I would not expect that. Before this study, I thought most of the cognitive slowing would probably come with people who have long COVID, but it shows you that even with mild illness, you have a little bit of this effect. And also wanted to share this. This actually came out last week. It was a challenge study, so it took healthy volunteers. This actually applies to folks like myself, the age of 22, 23. They took 34 unhealthy, unvaccinated, immune-naive volunteers in the beginning of COVID. I'm not sure why it took them so long to publish this. However, they compared their cognitive scores, executive function, memory scores, up to 1 year later. And they also found that there was a little bit of a reduction in the performance, in the cognitive performance. And interestingly enough, that the volunteers reported no persistent subjective cognitive symptoms. Again, take this of what you will, but it seems to affect the brain a little bit. We don't know exactly how. There's some theories. Again, an interesting effect on the brain. This was for people who are hospitalized. 351 hospitalized patients. Then they compared them to matched controls, and what they found was the cognitive deficits was equal to magnitude of 20 years of aging. That is quite remarkable, with objective evidence of ongoing brain injury and reduced gray matter volume. Now, we want to scare people. It's more of a be alert and don't have health complacency when it comes to repeated COVID infections. It's not just like the cold. I don't think we see this with the cold or with the flu. We do see with some other, I think there's one other virus, I think it's the name is not in my head right now, that they cause neurological complications, but for something like COVID, where it's so predominant, this much effect is quite alarming.
Okay, man, there was, if you look back, so I don't know about you, this scares the shit out of me. So the initial round of people that getting sick with COVID, you lost 20 years of brain function. Your neurons don't bounce back. They don't have this neuroplasticity. You can't just regrow neurons at your leisure. So we have a series of trials that show this, that people who got COVID and they didn't get very sick or they were fine, their brain function was reduced compared to people who never got COVID or say who never got COVID. And the people who got sick from COVID got the worst brain function. So we know that COVID's been shown associated with strokes. We know it's been shown with microthrombus in the brain. It's been associated with brain fog, cognition issues. So, my brain is getting old and it's wearing out, and COVID will accelerate that process. And some people who got initially very sick at the beginning, it's estimated they lost 20 years of their brain function. I'm not too happy with this information. I'm scared about this information. Now, the virus is not as strong as it was before, but these trends will continue. And people who say that I felt fine with my COVID, when you test their brain, it's not as sharp as the people who never got COVID.
Yeah, absolutely.
And these objective tests,
Absolutely.
it's non-randomized, it's observational, but it's very, very scary information.
Except this one. This was randomized challenge study. Very interesting and
these symptoms
controversial study as well.
They don't go away.
Yeah, no.
It's like you lose your brain function, you lose your brain function.
Now let's talk about the best way to prevent it is actually vaccination. We have this data right here showing people who are unvaccinated have higher risk, and then with each additional up to the third dose, we see reduction. We actually don't have good data beyond that. We only have observational data from two other prominent long COVID researchers. At the bottom right here, Dr. Tropol has written some reviews, and also Dr. Ali. He's been doing a lot of primary papers looking at the VA, the Veteran Affairs System, looking at long COVID. And their observational data showed that vaccination reduced long COVID risk by about 40%. I think Dr. Curnew mentioned that 40% mark as well. Some of the other potential things that have been mentioned and looked at, one was Paxlovid, we mentioned, as prevention, not as treatment. And convalescent plasma is another one in more severe cases, and steroids in the right person, of course. So the second phase, the inflammatory phase in the second week, that actually does a lot of damage. I was reading a review that they said for the brain effects, the brain deleterious effects, there was two potential hypotheses. One was hypoxia, low oxygen saturation, and one was the inflammatory phase that occurs. So we have some of these potential things. Again, the details you have to discuss with your physician and so on and so forth. And this
one slide. Go back. So the best way to prevent long COVID is go forward one slide and stop. The best way to prevent long COVID, next slide please, forward, stop, is don't get sick. Don't get COVID. So if people are sick, avoid them. If you're sick, don't get other people sick. During the Olympics, I can't believe this American super athlete has COVID and races. I think that's a very selfish act. I understand he trains all his life for this. I get it. It would have been better if everybody thinks that's okay. I don't think that's okay to make other people sick. So if you're sick, isolate yourself, test yourself if you can. And if you have COVID, ideally isolation for 5 days and wear a mask for another 5 days. So that's 10 days. Now I understand that life gets in the way and we can't always do all the things we want to, but that's the AT for preventing infection. Wearing a mask protects other people, and it protects you by reducing the chance of you getting respiratory illness by 30%. We have HEPTO filters. Yeah, it's about time that everybody think about getting a HEPTO filter. Be outside. You're 40 times less likely to get COVID outside compared to inside. I'm going to the Ticats game tomorrow, and the Ticats, I think, is 4 or 5 in a row. They're on the rampage right now, but it's a good place to be right now. And get your vaccines. Yes, there's reactions to the vaccines. They're pretty small and pretty rare at this stage. And if you get COVID, treat it with Paxlovid if you're at high enough risk. Steroids are for basically for sick people. Blood clot dissolving agents are for sick people. These are for hospitalized patients. And if you give steroids in the first week of COVID, you actually increase mortality because you allow the virus to replicate. During the second phase, this cytokine storm where your immune system is overactive, that's when you calm it down with steroids. It's amazing what we've learned so far. and I'm so tired about the politics of everything. We still have a lot more to go. Um, and the long-term effects. The thing that worries me the most is that what is getting COVID 2, 10, or 15 or 5 times of your lifetime going to do to your long-term health? I don't think it's going to be a good thing. I may be wrong, but I'm going to be cautious about this, and I'm going to take the steps I can to avoid making myself sick and make other people sick, and take the precautions, including vaccination. So you convince me if I get COVID, um, and I'm starting to have respiratory symptoms on day 1 or 2, I'm going for Paxlovid right away. If I because I'm 65 years of age, and so my immune system is that not of a 20-year-old. And I also learned is that you can strengthen your immune system by being skinny, exercise, controlling risk factors as well. Tell us more.
Right. So in terms of treatments, there's no approved treatment. Most of it is about symptom control. So some of the symptoms that comes with long COVID, and there's a list here. You can pause it and take a look. For some sleep disturbances, there's melatonin that has been looked at. Again, some of the citations you see here, not amazing evidence. They're just some of the things that has been tried. We talked about the gut microbiome connection. Probiotics have been mentioned. Breathing techniques for things like POTS and such. N-acetylcysteine. I don't know too much about that for executive function. SSRIs for mental health and depression, anxiety. The list goes on. Things are being worked on. I think one note of caution I should probably say is if you search for long COVID online, you will probably see some individuals, or maybe a lack of a better term, grifters, who probably try to sell you something. I remember I saw something a while ago. I think it was the anti-spike supplement. So just be careful with those things. There's nothing approved for long COVID. It's a complicated area for treatments.
So far, the best evidence so far is being vaccinated decreases long COVID by 40%. Even better, don't get COVID.
Absolutely. Again, it's one of those things where you want to prevent it, right? So again, with reinfections increases the risk. It's not just the first time and you think, I'm okay. Again, health complacency. We all have that. And last thought, we just wanted to leave everybody with this page. If you want to learn more, you can go into depth. They have office hours, microbe TV, ask all your virology questions, infectious disease questions, anything you have. Anybody who's curious, we encourage you to check this page out. It's lovely. They've grown over time. I think that he started in 2010, long time ago, and they've made quite progress.
This is remarkable. I encourage everybody to look at that. And I didn't learn this. Rad taught me about this, so we're still learning so much. So I learned that the immune system affects multiple areas of the body, and that you can ramp it up and you can ramp it down. And so one thing I hope people think about is that if you're overweight, lose weight. Building muscle is good for your immune system. Eating a healthy diet is good for your immune system. And again, the data is quite poor, but basically, if you have a good night's sleep before you get vaccinated, the effectiveness of the vaccine in one particular observational data increases the effectiveness of the vaccine by 40%. The current generation of the COVID vaccine is not a very good vaccine to prevent infection. It's a vaccine that has its impact on long COVID and severe illness, and that the disease changes and your immune system adapts pretty quickly. And so the amount of the effectiveness is highest in the first few weeks to few months, and then it wanes. So I think it's reasonable. Anybody over the age of 6 months get a vaccine every year. And older people that are at risk, such as diabetes, hypertension, over the age of 65, have cancers, autoimmune diseases, kidney failures, anemia. So you should get vaccinated every 6 months would be very reasonable. Could you get a bad effect of from the vaccine? Absolutely. The chance of that is very low. The two vaccines right now in Canada that we have is Moderna and Pfizer. The protein-based vaccine is not being purchased by the government at this point in time. So that's what's available. And I think this has been a wonderful bit of information that you've all taught us about, and we still have a lot to learn. The biggest fear is that what happens, it's rolling the dice. Will you? And what percentage of people go into long COVID, you think, Rad? Do you have a number of that?
Oh yeah, that's something I tried to find. So from the sources I've seen numbers as low as 0.1% to 20%. Again, in the beginning of COVID, the number was much, much higher. Now, people who get it, I can't tell, but there's the Canadian data. I saw 1 in 5, I saw 1 in 9, 1 in 15. I think 1 in 15 from the microbiology lectures. I've heard that number a few times. Again, it's not super rare, but 1 in 15, 1 in 20 is still quite remarkable.
I think it's, somewhere between 30 to 50% of COVID's asymptomatic. And I think that number is much lower. I don't know the actual number. I don't, and I think it's less than it was before. But to strike somebody in their 30s or 40s being inability to work to function properly from a few months to 2 years or even longer is devastating. And um, and so much to learn. And the part that scared me the most is when you heard that people were sick from COVID, uh, losing brain function equivalent to aging your brain of 20 years. That's a scary number. Also, we know that people who have infections, so you get simple flu, you can actually live longer by getting um, influenza vaccines um,
Yep.
during heart attack season, during the winter time, getting pneumococcal vaccine helps prevent heart attacks. Getting shingles vaccine prevents heart attacks. Um, we know that inflammatory diseases such as rheumatoid arthritis, psoriatic arthritis, all increase the risk of heart disease. So decreasing inflammation is a good thing. And COVID's the second week is that inflammatory phase that can take off in some people. We're better at treating it right now, but I think the best defense is not to get sick if you can, and vaccines are your best defense mechanism. So your choice. Um, and again, I vaccinate myself to protect me, to protect you, and maybe less mutations. I mean, so we can argue that how good of all of these sorts, but you told me very clearly severe disease and long COVID are
Yep.
the best effects of the vaccines. Is that a fair thing to
Oh,
say?
I think that absolutely. So long COVID and not so much long COVID, but any deleterious effect that's chronic, the brain,
Yeah.
diabetes as well, and severe disease, absolutely, and even mild disease. We mentioned moderate, being out for a week. So, um, I got very sick with, it wasn't COVID, but it was a cold a few weeks ago, and I was trying to prepare for a few running competitions. It took me back a while. I got COVID last February, and it took my preparation pretty much extended by a month and a half. So it's not
Yeah.
just those things as well. It's also the inconvenience. You can miss a lot of work, a lot of other activities, etc.
I know you just wrote an exam and you got sick before your exam. It wasn't COVID, but it ruined
Yeah, it was a really
ruined your
experience.
exam.
Yeah.
Being sick is never good. Um, and what I guess we're going to learn is that is having COVID multiple times a risk factor for cancer, heart disease, Alzheimer's disease, diabetes, um, and heart disease. And the answer is it's pretty suspicious, but we still have a lot to learn, and my mind is not made up on that, and I'm still learning. And I hope you keep an open mind and keep learning. And I want to thank you, Rad, Amber, and everybody else. Amber, anything else that you wanted to add to that?
No, I just want to thank Brad for preparing this amazing topic with like masks. It's not many people start to wear masks, and it like COVID rates decreasing. Well, not recently, but it had decreased previously, and people were just not less aware of it at a certain point. Now I've seen like more people get COVID again, so I think it's like a great awareness, a great reminder to for people to wear masks and everything.
Yeah.
And
You know,
thank you, Dr. Curnew, for
well, thank you
uh,
for all your hard work. And it's kind of we're going through a phase right now. People are tired. I get it, but ignoring a problem doesn't make it go away. Um, and I think we got to that phase there, and I'm grateful for all what we learned and what we're still going to learn. Um, Wonderful knowledge that you shared. If we backtrack one more slide, I would really encourage people to go to Micro TV, and what these experts talk about is that they feel very strongly about Paxlovid. If you're over the age of 65 or has risk factors, And they remind us that in the United States right now is 1 to 4% of mortality per month is related to COVID. And most people who get COVID have other illnesses as well. We have most of us, as we get older, have chronic disease. And we also realize that the last few years of life can be spent in illness or in health. So what I'm encouraging people to do is to become active. So what I'm doing is I'm trying to is really exercise 14 hours a week, vigorous activity, increase muscle, lose fat. I during this presentation I took my cholesterol pills again. And I'm going to take, I just had an 8 during this presentation, and to basically lower my blood sugar, I should try to go for a walk after every meal for about 10 minutes to lower my blood sugar. So there's just so many things you can do for your health. And basically, you know that COVID can probably damage your pancreas too as well. So much to learn. Thank you, Rad. Thank you, Amber, for all your insights. Next slide, please. And I thank my wonderful staff, my wonderful clinic, the people around me, my patients, and we'll do the best we can to help. And I'm blessed with the world's best clinic because of these young minds from McMaster and others, and wonderful staff. And I'm still curious, still wanting to learn. And COVID has just given me a new way of looking at the world, and good and bad. Thank you.
No, I think the last slide, stack the odds in your favor and try to prevention. That's all. So you're a preventive cardiologist. I also wanted to work on prevention myself, and vaccines are probably the cornerstone of that. So I hope we got the message across.
And we have, and when's the CN Tower coming up?
November 9th. We have it right here, November 9th. If you want to go Curnew climbers, you can join us, join our team. We go at 6 a.m. Ignore the deadline here of August 30th. That was for the discount. November 9th at 6 a.m. Anybody wants to join us in the climb, please do so. It's a big challenge.
And I thank Darren for a nice squash match this morning, and some burpees and some push-ups as well. So I bid everybody good night. Thank you so much.